Morning, everyone. My name is Mel Nolasco, and I will be presenting a case of an adult patient that has been seen in a clinic for a pulmonary complaint. I'm going to start off with the identification. So, this is MR, a patient who's 72-year-old Hispanic male, presented to the clinic for a short breath and cough that has been going on for a week. He was accompanied by his wife. Um, so my chief of complaint is he's been having a cough, short of breath for about a week. Um, so history of present illness or HPI would be a 72-year-old male with a past medical history of hypertension, type 2 diabetes, COPD. Present to the clinic for a 7-day history of productive cough, dyspnea or short breath or fatigue. The cough has been described as persistent and productive of with a yellow green sputum. He reports associated short breath, particularly with upon exertion, and a mild pleuritic chest discomfort when coughing. He denies hemoptysis. Um, He also he stated the symptoms began gradually and have worsened over the past 3 days. He reports subjective um, febrile and chills, but did not measure his temperature at home prior coming to the clinic. He denies recent travel or known sick contacts. He has been using his home albuterol inhaler with minimal relief. So for my past medical history, I have hypertension, diabetes, and COPD, which he was diagnosed 5 years ago. He's currently taking lisinopril 10 milligram daily, metformin 500 milligram twice daily, and albuterol inhaler as needed. No allergies noted. Social history. He was a former smoker. 40 pack year history. Quit 5 years ago. Um, he denies alcohol or illicit drug use. He stays at home with his wife. My review of review of systems, or my focus assessment will be positive for cough, um, dyspnea, fatigue, fever, negative for chest pain, at rest, or no palpitations noted. No leg swelling, no nausea, vomiting. My objective findings will be vital signs are the temperature is 100.8 when it checked oral, blood pressure is 138 over 82, heart rate is 96, respiratory rate is 22, oxygen saturation is 91% in room air. Generalized appearance, he looked mildly ill, alert oriented for no acute distress, but yeah, he's mildly dyspneic when upon exertion or speaking. So my pulmonary exam will be decreased breath sounds in the right lower lobe, crackles noted on the right lower lung field, no wheezing appreciated, or no wheezing heard. My cardiovascular is regular rate and rhythm, no murmurs, ENT, no nasal congestions or any sputum at that time, or pharyngeal erythema. Extremities are good, no edema, no cyanosis. So my assessment would be a 72-year-old male, Hispanic male with COPD presenting with acute onset of productive cough, fever, dyspnea, and focal lung findings, which is concerning me for a lower respiratory infection. So my differential diagnosis, my first one will be community acquired pneumonia, um, given with the given symptoms. My second one is COPD exacerbation, given with the history of COPD and dyspnea, and acute bronchitis, less likely due to abnormal lung exam or hypoxia. Um, Fourth and fifth, pulmonary embolism, congestive heart failure, likely to cardiac findings. But my final diagnosis would be community acquired pneumonia affecting the right lower lobe. So my plan will be diagnostic wise, chest X-ray, um, CBC just to assess the white counts, basic metabolic panel, electrolyte status, and pulse ox monitoring at home. Um, Pharmacological management will be initiate empiric antibiotic therapy with augmentin or amoxicillin with clavulanate, and also plus azithromycin due to his comorbidities. Continual butyl inhaler is needed for dyspnea or short of breath. My non-pharmacologic management would be encourage rest, hydration, and deep breathing exercises and coughing techniques. Patient education will be monitor for signs of worsening conditions such as increased short breath, chest pain, confusion. Advise go to ER urgent care. Uh, Make sure finish the whole course of antibiotic therapy to avoid the resistance. Um, Follow up will be about 48 to 72 hours or sooner if needed. Consider hospitalization if oxygen saturation drops below 90% or clinical status deteriorates. So, I mean, so far right now, the oxygen is about 91, 92%. So, given the fact that he has COPD, so my conclusion will be this case. It shows me the importance of differentiating the between COPD exacerbation and pneumonia, in especially with the elderly patients um, presenting with different various respiratory symptoms. Given the fact there was a fever, productive cough, vocal lung findings, it guided me through the diagnosis um, toward the community acquired pneumonia. My early recognitions or early recognitions, appropriate antibiotic therapy are essential to reduce mortality and morbidity, especially for older adults with accompanied with other conditions. Clinical judgment will combine with evidence-based guidelines for optimal patient outcomes. And that was it. That was my case. Thank you.